Good evening, sir. My topic is preemptive analgesia. The post-op pain is a type of nociceptive pain that originates from the tissue damage due to trauma caused by surgery. Preemptive analgesia is defined as a treatment started before surgery to prevent repetitive firing of C fibers or to reduce the establishment of sensitization of dorsal or neuron caused by the tissue injury. It consists of giving analgesics before tissue injury, that is before reception, transmission, modulation, and nociception of aggressive stimulus, aiming to prevent hyperalgesia. Preventive analgesia, where the timing of analgesic treatment in relation to surgical insult, that is before, during, and after surgery. The anti-nauseous treatment includes attenuating the pain from higher intensity nauseous stimulus before, during, or after the insult. Pathophysiology. The tissue injury produced biphasic response, peripheral sensitization and central sensitization. Peripheral sensitization is due to local release of neurotransmitters, substance B, prostaglandin, bradykinin, serotonin, and histamine. Central sensitization, continuous barrage of afferent input from the site of injury. Noxious stimulus sensitizes the nervous system to subsequent stimulus and cause hyperalgesia and allodynia. The preemptive analgesia is to prevent sensitization. Two essential requirements include establish effective level of analgesia and inhibit the inflammatory mediators. The goal is to reduce the intensity of acute post-op pain and decreases the need for post-op analgesic medications, especially opioids, and minimize the opioid-related side effects and decrease the risk of developing chronic post-surgical pain and early mobilization and shorter hospital stay. Principles: the depth of analgesia should be adequate to block nociceptive input, and technique of analgesia should be extensive to include entire surgical field, and duration of surgery should be include surgery and post-surgical. Techniques includes various pharmacological and regional techniques. Drugs including opioids before surgeries, NSAIDs, COX-2 inhibitors, paracetamol, ketorolac, and hydroxycoke. NMDA receptor antagonist, ketamine, and magnesium sulfate, which both inhibit central sensitization. Gabapentin and pregabalin, which inhibits a neurotransmitter release in spinal cord, which should be given 1 to 2 hours before surgery. Alpha-2 agonist, dexmedetomidine, and dexamethasone, which decreases the release of inflammatory mediators, normally 4 to 8 mg. Non-pharmacological strategies include patient education, which should decrease the anxiety, and we should use minimally invasive surgical techniques, optimal position and padding. Regional techniques include local anesthetic infiltration before incision, nerve blocks, and epidural anesthesia with a catheter in situ, and subarachnoid block. This effectiveness depends on the type of surgery, specific analgesic agent used, and timing and dosage of administration. Therefore, preemptive analgesia is a multimodal approach of reducing pain throughout the perioperative period to minimize the sensitization and decrease the long-term outcome.
Cpsp also you are talking?
Sir,
you talked about preemptive. Who is talking about
chronic post-surgical pain? I am doing, sir.
You are doing. Okay. You also finish that, we will discuss it.
yes, sir.
Okay, sir. Chronic post-surgical pain. Chronic post-surgical pain is included in ICD 11 in 2019, and it is defined as pain that develops or increases in intensity after a surgical procedure or tissue injury. Pain persists beyond the healing process, that is more than 3 months after the triggering event. Localization either at the surgical or areas of injury are projected onto the innervation area of a nerve in this area, are related to the dermatome, or in the head zone after the surgery or injury to deep somatic or visceral tissue. Other causes of pain, pre-existing pain condition, infections, malignancy are excluded. Chronic post-surgical pain can often show characteristics of neuropathic pain. It is distinguished between tissue trauma arising from controlled pressure in the delivery of the healthcare and forms of uncontrolled accidental damage. Mechanism and characteristic of chronic post-surgical pain. The pathophysiology includes peripheral sensitization at the site of injury and central sensitization, which includes spinal and supraspinal sensitization. The inflammatory and the immune response to axonal and tissue damage, including the release of neurotransmitters peripherally as well as the spinal cord, leads to microglial activation, ectopic neural activity, and altered activity in the dorsal horn. There are also changes in the supraspinal processing, including the brain network connectivity, and also changes in the endogenous and descending pain modulation. Due to central sensitization process, the typical clinical symptoms like hyperalgesia, which is increased painful sensation caused by noxious stimuli, allodynia, which is a painful sensation caused by non-painful stimulus, dysesthesia, which is unpleasant touch perception or tingling, develop very early after surgery. Some of these can be tested by quantitative sensory testing yearly after the surgery. The increased incidence after thoracotomy, mastectomy, and amputation are seen. In thoracotomy surgeries, injury to the subcostal nerves are common. In mastectomy surgeries, injury to the brachial plexus and axillary plexus are common. Patients with a neuropathic chronic post-surgical pain report more intense pain, greater limitations in the activity of the daily life, and reduced quality of life. Other mechanisms like visceral, inflammatory, and neuropathic pain may play a role in knee surgery, hip surgery, abdominal surgery that are less likely to be associated with neuropathic pain. The risk factors of chronic post-surgical pain may be preoperative risk factors, intraoperative post-operative healing period, and delayed post-operative period. The preoperative risk factors include anxiety, catastrophizing, depression, genetic, impaired pain modulation, pre-existing chronic painful conditions like fibromyalgia, migraine, low back pain, long-term use of opioids, other pain states, sleep deprivation, stress, young age, high BMI, female sex, socioeconomic factors are preoperative risk factors. Whereas intraoperative and postoperative healing period, the risks include type of surgery, nerve injury, tissue ischemia, anesthetic technique, pain formulation or amplification, pro-inflammatory state, opioid use, and acute postoperative pain with a stronger intensity duration of more than 5 days. Delayed postoperative period, postoperative pain or hyperalgesia, chemotherapy or radiation therapy, repeat surgery, and psychosocial factors. Prediction of Cpsp. It is done by quantitative sensory testing to assess the peripheral sensitization and the central sensitization process. Increased sensitization before surgery by quantitative sensory testing increases the risk of Cpsp. Prevention and treatment includes pharmacological interventions and non-pharmacological interventions. The pharmacological interventions are ketamine. Perioperative ketamine decreases the opioid consumption, which decreases the acute post-op pain. The more apparent in patients receiving opioids preoperatively. Gabapentinoids, they can reduce the neuropathic pain and used in the procedures that results in nerve damage like complex pain surgeries. The treatment effect on pregabalin on Cpsp after 3 months in patients who underwent cardiac surgery and total knee arthroplasty has been found. IV lignocaine. Lignocaine IV for 24 hours helps to reduce Cpsp in patients undergoing breast surgeries. Other drugs includes duloxetine, which is a serotonin noradrenaline inhibitor, which improves patients with pain in diabetic polyneuropathy by having an impact on the descending pain modulation. In patients with increased sensitivity to pain, this duloxetine reduces the post-op pain 12 weeks after surgery. Other drugs can be used are clonidine and dexmedetomidine. Regional anesthesia. Perioperative regional anesthesia decreases the risk of chronic post-surgical pain by blocking the nociceptive input to the central nervous system. Sensitization process can be reduced. Epidural analgesia in thoracotomy. Paravertebral blocks in thoracotomy and breast surgery and can reduce the incidence of Cpsp. And continuous wound infiltration reduces the chronic pain after C-section and iliac crest bone grafting procedures. Reduction in opioid use. Pre-op opioid consumption is a major risk factor for Cpsp. The mechanisms include induction of opioid tolerance, changes in the central reward system, facilitated central sensitization, and altered descending inhibition. The reduction of the pre-op opioid consumption by 50% improves outcomes 6 to 12 months after knee surgery has been found. Increased intra-remifentanil increased the incidence of CPSP, but total intravenous anesthesia with low dose remifentanil has been reduced. Incidence of CPSP has been found. Multimodal analgesia, regional anesthesia, and ketamine use decreases the incidence of CPSP. Use of nociception monitors like pupil diameter and heart rate variability, surgical plethysmographic index, anesthesia nociception index, and a nociception level index help to decrease the intra exposure to opioids. The non-pharmacological interventions include multidisciplinary approach, including physiotherapy, psychological support, and follow-up after several weeks after surgery should be done. That's it, sir. Thank
Okay.
you, sir.
So after knowing about the physiology of pain transmission, there are two subsets of questions commonly asked in the theory. One is preventive analgesia or preventive analgesia, which is also known as preventive analgesia. That is, you give analgesic agents before the noxious stimulus is inflicted on the patient. And that is supposed to have a long-term effect of reducing the need for too much of analgesic drugs in the form of opioids, and give a better outcome and hemodynamic stability in these patients. The second half is even after 3 months of surgery, patients have continued to have the pain, due to so many reasons. It may be psychological, which may be wrong surgery, or a nerve which has been cut, which formed a neuroma, or infection which has occurred and delayed the wound healing, or placement of an extraneous material like a mesh in hernia surgery. So all these several causes are there for chronic post-surgical pain, which has been identified as a specific entity in some patients. And so that has to be tackled, and we must know what are all the causes which can lead to this post-surgical pain, and rectify them so that patient will have a free and smooth post-operative period, and long-term post-recovery also will be good. So we'll just share the screen for that and see what has to be done.